Hi, my name is Dr. Mariam Barkodarian. I'm an internal medicine resident at Palisades Medical Center and a cardio nurse fellow. I'm excited for the AHA Scientific Sessions 2024 happening in Chicago from November 16 to 18, with a special pre-session symposia and early career day on November 15. AHA is also featuring quality of care and outcome research programming and an international symposium on November 15. I'm really looking forward to this year's expanded fellow in training in women in cardiology programming. It's AHA's 100th birthday. I'll be there along with the Cardio Nurse Conference scholars, so be sure to register today at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi everyone, Dan Emmender here. On behalf of all of us at Cardio Nerds, we are thrilled to bring you our Decipher the Guideline series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and for educational purposes only. This series was developed by Cardio Nerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college students through advanced fellowship with mentorship from Dr. Anu Lala, Dr. Robert Mentz, and Dr. Nancy Schweitzer. We thank Dr. Judy Bezanson and Dr. Elliot Antman for their guidance. So join us as we get to learn about the guidelines and beyond from 16 leading faculty experts. With that said, it's time to get nerdy.
The following question refers to sections 7.4 and 7.5 of the 2022 AHA ACC HFSA Guidelines for the Management of Heart Failure. The question is asked by Cardio Nerds intern Akiva Rosenzweig, answered first by Cardio Nerds FIT Ambassador Dr. Jenna Skaronsky, and then by expert faculty Dr. Randall Starling. Dr. Starling is professor of medicine and an advanced heart failure and transplant cardiologist at the Cleveland Clinic, where he was formerly the section head of heart failure, vice chairman of cardiovascular medicine, and member of the Cleveland Clinic Board of Governors. Dr. Starling is also past president of the HFSA back in 2018 to the 2019 term. Dr. Starling was among the earliest Cardio Nerds faculty guests and has since been such a valuable source of mentorship and inspiration. Dr. Starling, thank you so much for everything you've done for Cardio Nerds and the community at large, and it is such a pleasure to have you back on the show.
It's a pleasure to be here. Thank you.
All right, Akiva, let's hear the question.
Thanks so much, Amit. Hey, Jenna, I have a patient who has heart failure and moderate to severe mitral regurgitation, and I'd love to hear your thoughts on her management. So here goes. Mrs. M is a 65-year-old woman with non-ischemic dilated cardiomyopathy with an ejection fraction of 40% and moderate to severe mitral regurgitation, presenting for outpatient follow-up. Despite improvement overall, she continues to experience dyspnea on exertion with 2 flights of stairs and occasional PND. She reports adherence with her medication regimen of sacubitril-valsartan, 97 and 103 milligrams respectively, twice daily, metoprolol succinate, 200 milligrams daily, spironolactone, 25 milligrams daily, empagliflozin, 10 milligrams daily, and furosemide, 80 milligrams daily. A transthoracic echocardiogram today shows an LV ejection fraction of 35%, an LV end systolic diameter of 60 millimeters, severe mitral regurgitation with a regurgitant fraction of 60%, and an estimated right ventricular systolic pressure of 40 millimeters of mercury. Her EKG shows normal sinus rhythm at 65 beats per minute and a QRX complex width of 100 milliseconds. What is the most appropriate recommendation for management of her heart failure? A. Continue maximally tolerated guideline-directed medical therapy with no other changes. B. Refer for cardiac resynchronization therapy, or CRT. Or C. Refer for transcatheter mitral valve intervention.
Hey, Akiva, thanks so much for that question. So many of our patients have mitral regurgitation, so it's really important we know how to manage them. The correct choice for this answer is C. Refer for transcatheter mitral valve intervention. The 2022 AHA-ACC Guideline for the Management of Patients with Valvular Heart Disease outlines specific recommendations for this patient. In patients with chronic severe secondary mitral regurgitation related to their LV systolic dysfunction, so LVEF less than 50%, who have persistent symptoms, which we would qualify as NYHA class 2, 3, or 4, while on guideline-directed medical therapy for heart failure, a transcatheter edge-to-edge repair, or a TEER, is reasonable in patients with appropriate anatomy as defined by transesophageal echo and an LVEF between 20 and 50%, an LV end systolic diameter less than 70 millimeters, and a pulmonary artery systolic pressure less than 70 millimeters of mercury. Conversely, mitral valve surgery may have a role in the following contexts: severe secondary mitral regurgitation when a CABG is planned. Another situation would be a chronic severe secondary mitral regurgitation related to an atrial annular dilatation and a preserved LV systolic function, so an LVEF greater than 50%, who have severe persistent symptoms, again, NYHA class 3 or 4, despite therapy for heart failure and therapy for their associated atrial fibrillation or other comorbidities. And then another situation that a surgery would be indicated would be chronic severe secondary mitral regurgitation related to LV systolic dysfunction, so an LVEF less than 50%, who have persistent severe symptoms, so NYHA class 3 or 4, while on optimal guideline-directed medical therapy for heart failure. Choice A, or the option continue maximally tolerated GDMT without other changes, is incorrect. GDMT has been shown to improve mitral regurgitation and LV dimensions in patients with HFrEF, heart failure with reduced ejection fraction, and secondary mitral regurgitation. And it's a class 1 recommendation to optimize GDMT before any intervention for secondary MR related to LV dysfunction. This includes both guideline-directed medical therapy and cardiac resynchronization therapy, or CRT, where appropriate. Our patient is still having symptoms despite being on maximally tolerated doses of medical GDMT. This highlights the importance of a multidisciplinary approach to management of valvular heart disease in patients with heart failure in accordance with clinical practice guidelines to prevent worsening heart failure and adverse clinical outcomes. A cardiologist with expertise in the management of heart failure is integral in the shared decision-making for valve intervention and should guide optimization of guideline-directed medical therapy to ensure that medical options for heart failure and secondary mitral regurgitation have been effectively applied to these patients for an appropriate time period and exhausted before considering intervention. Choice B, or refer for cardiac resynchronization therapy, CRT, is also incorrect. While CRT has been shown to improve mitral regurgitation, LV dimensions, and outcomes in patients with heart failure and secondary MR in appropriately selected patients, our patient would not be a candidate given that her QRS duration is less than 120 milliseconds. So our main takeaway from this question is that in patients with severe secondary mitral regurgitation and reduced ejection fraction with persistent symptoms despite GDMT, a transcatheter edge-to-edge repair is reasonable in patients with appropriate anatomy as defined by transesophageal echocardiogram and with an LVEF between 20 and 50%, in addition to an LV end systolic diameter less than 70 millimeters and a pulmonary artery systolic pressure less than 70 millimeters of mercury. Conversely, surgery may be appropriate for some of these patients. Heart failure and valvular heart disease should be managed in a multidisciplinary fashion. Dr. Starling, what are your thoughts on this question?
Thank you for that case presentation, which I think is an excellent example that exemplifies this particular situation, which is a patient that has been treated with excellent GDMT. So why do I say that? I say that because this patient is receiving all of the main drugs and the patient is on doses of medications that are also quite significant. So the first cornerstone, I think, of GDMT is deploy all 4 drugs and titrate to maximal doses. Number 2, acknowledging the fact that if the patient is a candidate for CRT is also essential. Why is that? Well, both for medical therapy as well as CRT, either or both can affect reverse remodeling and attenuate the degree of secondary mitral regurgitation. When you see that occurs in conjunction, most typically with a reduction in left ventricular end diastolic dimension and end diastolic volumes, and an improvement in coaptation with a subsequent reduction in mitral regurgitation. So when all those criteria have been met and the patient still has 3 to 4 plus mitral regurgitation, and the other criteria that were mentioned, including a PA systolic less than 70, an increased left ventricular size, and a reduced ejection fraction, they are a prime candidate for a procedure that can be done percutaneously. And the source data from that, of course, is the COAP study. And I would go one step further and elaborate on the fact that this was correctly cited as level 2A. And there are definitely individuals that were involved in this trial that feel that it should be level 1. Why is it not level 1 as far as strength of evidence? Well, I'll just mention briefly that there were essentially 2 concurrent trials. One was the COAP study, which took quite a long time to fully enroll in the US, and then the mitral FR, which was primarily in Europe. The COAP study was positive, and it was strikingly positive because it reduced cardiovascular mortality as well as heart failure hospitalizations. Mitral FR was a negative study. Without elaborating, there were many differences between the 2 studies that likely explain that. There will be additional studies presented in due course, which I expect will confirm and add to the body of evidence as to the benefit of reducing mitral regurgitation in this setting. So I would close by saying that where I work, I see anywhere from 2 to 4 to 5 patients a week that come to me that are referred to Dr. Goyle and his colleagues in interventional cardiology for percutaneous treatment. My job as a heart failure specialist is to ascertain and confirm that their GDMT is optimized, that their CRT, their atrial fib, et cetera, has all been adequately treated. And if not, that patient is deferred from a mitral procedure until everyone is comfortable, including the heart failure specialist, that the MR is persistent despite optimization of GDMT. Thank you.
Thank you so much, Jenna and Dr. Starling, for such an enlightening conversation on the indications for percutaneous management of valvular heart disease in patients with heart failure.